let's get started, and everyone can carry on joining. I think we'll get started because we do have a lot to get through. So, hi everyone. Welcome to our COVID behaviour change webinar on vaccine uptake 101. This is going to be an extended webinar stroke workshop where we will be exploring the key principles and practical challenges in the promotion of vaccine uptake in low and middle income countries. So thank you all for joining us today. This is the first of the next set of webinars in this very long running series, which is hosted by the FCDO's COVID Behaviour Change Forum, which many of you are part of, in conjunction with Unilever, the Vaccine Data Collab, and the COVID-19 Hygiene Hub at the London School of Tropical Medicine, Hygiene and Tropical Medicine. So based on feedback from lots of you, we're going to make this more interactive and have plenty of time for discussion and sharing between all of you. So this is going to be 1.5 hours. And we will be doing some breakout groups after we hear from our presenters. I will run through the agenda in a moment. I'm just going to introduce everyone first. I'm Pippa Ranger. I'm the Innovation Behaviour Change Advisor, and I run the Behaviour Change Forum, which is a network for sharing, learning, connecting and collaborating. I'm facilitating today's workshop with Sian White, who is the Research Fellow at the London School of Hygiene and Tropical Medicine's Environmental Health Group, and she's the co-director of our Hygiene Hub. If you would like to introduce yourselves too, please do so in the chat. I can see lots of things popping up with who you are and where you're joining from, organisation and country, and how you're feeling today. So now I'm going to introduce our speakers. Lisa Menning, I'm very delighted to welcome Lisa Menning from the WHO and Dr Ruth Lawson from the FCDO, who are going to be sharing the latest frameworks, guidance and learnings for increasing vaccine uptake. So Lisa Menning is the Demand and Behavioural Sciences team lead in the Department for Immunisation, Vaccines and Biologicals at the World Health Organization. Lisa and her working group have developed the behavioural and social drivers for vaccine uptake framework, which she will be taking us through today. And also Dr Ruth Lawson, who's the Senior Global Health Security Advisor for the FCDO, who's based in the UK office to the African Union in Addis Ababa. Ruth's the lead advisor on COVID-19 and vaccines for our Africa Regional Department, which supports all our country offices across the region. And she's going to be sharing some lessons learned about facilitating vaccine uptake across Africa. So welcome both of you, and thank you so much for joining us and making the time today to share your learnings and guidance. There's going to be a whole team of people behind the scenes. So Sam and Gita from the Vaccine Data Collab, Rhodes and Lisa from FCDO, and Neris, and then Jenny also from the Hygiene Hub. There's going to be plenty of opportunities to ask questions for discussion, and then we're going, after the presentations, we'll have a short Q&A, and then we will go into breakout groups to explore barriers and opportunities in more depth. So we really hope that you're going to walk away with some valuable insights and ideas to apply to your work directly, but also have some clarity on the key terminology and principles to support vaccine uptake, especially for in terms of social and behavioural drivers, and a bit more understanding of the barriers to uptake in low and middle income countries, and to have had an opportunity to discuss these and draw on recent learnings to identify some potential solutions. So just a few housekeeping things. Please do keep yourself on mute and use the chat or raise your hand to ask a question. There will be opportunities throughout to do so. If you lose us in the breakout groups, just come back into this main room through the invite joining instructions, and Rhodes will help you find your group again. If you're having any other issues, do just let us know. We are recording this and we'll be sharing it on the Hygiene Hub's website. So on that note, I'm going to hand over to Sian, who's going to get us started with some polling questions.
Thanks very much, Pippa. Ida, could you skip forward a couple of slides, please? Great, thank you so much. Great to be joining you all today and looking forward to the webinar ahead. We thought we'd start this morning or this afternoon, wherever you are, with just understanding a little bit about your experiences with vaccine promotion to date, and what your experiences are in terms of the challenges as well. So I'll ask Rhodes to start our first poll, and you'll see this appearing in the chat. So we encourage you each to vote for your experiences. So the first question is simply, has your organisation been directly involved in vaccine promotion to date? Simple yes or no question. And our second question is around the experiences that you've had in terms of the challenges of actually doing vaccine uptake in your settings. And so we've got a few different options here. We've got challenges in terms of supply and access barriers, in terms of actually getting the vaccine, misinformation about the vaccine, a lack of trust in authorities or the health system, low risk perception around COVID-19, or perhaps there are other factors in your setting. So you can hopefully see those all in the chat at the moment. As you vote, you'll see them sort of the responses appearing. So we can see already that we've got about 63% currently who have said that yes, their organisation is already involved in vaccine promotion, but the other half perhaps having less experience in this so far. I imagine many of you are planning to do vaccine promotion work in the coming months. And then in relation to our second question, some of the most common responses that we're seeing coming in are challenges related to misinformation about the vaccine, and also sort of the period of the pandemic where we're now in, where there might be a lower risk perception related to COVID-19 and other priorities among the populations. So if you haven't voted, I would encourage you to continue to vote, but that's really useful kind of understanding of who's in the room today and the challenges that you've faced. With that, let's jump into our first presentation. So our first presentation is going to be from Lisa Menning, who Pippa already introduced. And Lisa is going to tell us a little bit about the sort of social and behavioural drivers of vaccine uptake and the work that they've been doing on trying to assess these drivers, and sort of support work that's going on globally. So over to you, Lisa. Thanks.
Thanks a lot, Sian, and thank you also, Pippa, for the introduction, and it's really a pleasure to join you all today. So as previewed in this presentation, I'm going to provide an overview of work that we've done over the last 3 years, in fact, in developing globally field-tested and validated tools to support programs to understand exactly what are the reasons for low vaccine uptake, and to be able to address those barriers and drivers accordingly. So I'll whiz through this and happy to take any questions later. And just firstly, starting with a little bit of the global context for immunisation programs. And essentially, as I'm sure you're probably aware, we measure immunisation program performance by the coverage of key vaccines. And here we're looking at the coverage per region of the DTP3 containing vaccine, the diphtheria, tetanus, pertussis, the third dose of that vaccine, and looking at these trends since 1980. And overall, where we see the zoom in to data across the last 5 years from, a period from 2016 to 2020, we've seen a real plateauing of progress here, and even a decline in 2019-2020, and that's actually data reported in 21 for 2020. So there's a little bit of a 1 year reporting lag in this data. But even prior to the pandemic and in 2020, we had seen this stagnation and then a decline in coverage due to those pandemic-related disruptions. And we saw some of those disruptions mainly in the Southeast Asian and Eastern Mediterranean regions, but also variously in a lot of other regions and countries around the world. And as you can imagine, these curves mask a lot of differences between and within countries. And even as we've tracked coverage over the last year for 2021, we are still seeing these disruptions continue. At the same time, there has been a huge amount of attention on hesitancy. And this chart represents the number of papers mentioning hesitancy since 2014. And we've seen almost an exponential increase in the number of these mentions. So there's been a lot of attention on hesitancy, but also a lot of referral to concepts like confidence and acceptance, demand, uptake, and then also even around that, anti-vaxxers, misinformation, and so on. And what we really wanted to do ultimately was really to help programs to better gather local data to truly understand what are the root causes for low uptake and be able to address them in a well-informed manner and to evaluate from there. So this field in many ways has seen a swirl of attention and focus on hesitancy, and we really wanted to make sure that we understood what these real issues were. But at the same time, we were aware that current measures available to immunisation programs focused primarily on hesitancy, attitudes, sometimes motivations, but much less, if ever, on practical and logistical barriers. These barriers that relate to the ease and convenience of even just getting to a point of service. And most of these measures were not validated, let alone being globally validated, not standardized, didn't allow for systematic tracking of trends between or within settings over time. And this data was rarely used even for the systematic design and then the evaluation of interventions to really establish what was being effective at a local level. And so we were really not well equipped to systematically understand these issues and use this data at all the various levels for our planning and tracking and monitoring. So in late 2018, with a group of partners, we undertook an effort to develop such tools, and we got together a global expert group with experts from many disciplines and geographies around the world, many partners, and we went through this development process. And I won't talk to the detail in this slide, but just highlight a few points. We first looked at the literature, we mapped out existing tools, and went through just a process of looking at what existed, what was out there, and mapped out some initial constructs and used that as a basis for developing tools. And throughout the process, we've had consistent routine interactions with different types of end users, key informants, and other immunisation program structures and coordination advisory mechanisms in this space as well. So we did this first step in just developing and drafting the tools. We then went into a field testing phase in a range of countries around the world that included initial translation, testing, cognitive interviewing, and that included testing out our survey tool, but also the qualitative guides. We could then also at the same time got a lot of feedback from different types of program partners and end users. We then went into our validation phase in 6 countries, and we identified these countries based on the greatest number of under-vaccinated children for routine immunisation. We had planned this out in late 2019, in fact, and that just consisted of implementing the tools, gathering data, and doing a lot of data analysis of psychometric validation to look at, for example, the predictive validity of these tools as well. And lastly, then many more iterations of finalization of the tools and development of corresponding guidance that would support the use of these tools. So the little bit of local testing and tailoring, but then collection, analysis, and use of that data as well. And all of this work culminated last year as we presented everything to WHO's Strategic Advisory Group of experts on immunisation, who recommended systematic gathering and use of data on these behavioural and social drivers globally. And like I mentioned, we initially set out this work for childhood vaccination, but of course, with the pandemic, we extended on that for childhood vaccination, for COVID vaccination in 2020 as well. So we now have a package of tools and guidance for childhood and COVID vaccination. For the survey, we're talking to parents of children under 5, and for COVID, the surveys are targeted to adults and health workers, the two main priority groups at the outset, and we have these corresponding qualitative tools, the interview guides for use that enable us to gather a deeper understanding. And we also have this very practical, action-oriented, operational guidance that comes with the actual tools that takes the end users through the process of how to plan, gather and use this data, etc. And here's the link to where to find these tools. So what are we actually measuring? And this is a framework that we developed and also adjusted throughout the entire development process for these tools as we were gathering data and making those refinements to the survey questions, response options, and also the various constructs. And this is the same framework that we've established for childhood vaccination and COVID. And we're measuring against these 4 domains. Firstly, thinking and feeling, and this is where we situate perceived disease risk, and confidence, which is about the perceived benefits and safety and trust in the health workers and system. Social processes is where we situate social norms, a health worker recommendation, and gender and equity related barriers as well, and a few other constructs there as well. Then typically we've seen that these shape motivations or intentions or willingness to get vaccinated. This is where we situate hesitancy, and then an ability to carry through with those motivations or intentions is typically shaped by, or could be facilitated or hampered by, these practical issues. So the availability, affordability of vaccination, ease of access or convenience in relation to that point of service, the experience on site, and a few other factors there as well. And we use this framework to really help us to understand these exact drivers and to put adequate focus on these practical issues. And we have developed this specifically for vaccination. So you may see a few parallels here in places with other behavioural models that you might be familiar with, but this is specific to vaccination, the vaccination behaviours that we're looking to support. So just a couple of extra words on hesitancy, given this is such a hot topic. So we have defined this as part of the motivation domain. This updates on WHO's previous work as well, where hesitancy was defined by a working group in 2014 that also presented work to SAGE, our advisory group of experts on immunisation, that at the time defined this related to 3 C's: convenience, confidence, and complacency. So this is an update on that previous work, and we're really, based on evidence and expertise and our data here, identify and define hesitancy as this motivational state of being conflicted about or opposed to getting vaccination. And it includes these intentions or willingness. Also a word on confidence. This is part of the thinking and feeling domain. That's where we have attitudes and beliefs. So confidence is the belief that vaccines are effective, safe, and part of this trustworthy system. And this is separate to, but can contribute to, hesitancy. And also as part of this work, we have defined our behavioural and social drivers specific to vaccination, being these beliefs and experiences that we can modify and act on to boost uptake. And here are some further details on each of these 4 domains that I've explained already. So moving on to take a closer look at what we're actually measuring. And this is just a look at all of the constructs or themes for our childhood vaccination survey. And just to unpack this a little further, and specifically here, I want to pinpoint the constructs shown in red, which correspond to our priority questions or priority indicators. And these are the ones we are most strongly recommending for routine and consistent use and integration as and where possible into existing immunisation program data collection processes or activities, assessments, surveys, what have you, and also perhaps a supplementary use as and where feasible. So this just offers at a glance a look at all of the constructs that correspond to a single question in our survey, and we identified these based on performance in the testing and validation process. So the constructs and questions here are those that performed the best globally, that gave us the most information, that were most predictive of uptake, and also those that were the most stable or comparable between different settings. Between, for example, where we gathered this data in Angola, Nigeria, India, Pakistan, for example, in these very diverse settings for language and culture as well. Also importantly, noting that we have these demographic items that then enable us to carry out, use that as a basis for further analysis in various ways. So just a quick look at our priority indicators and giving you a sense of how our survey is constructed as well. So for each of our 4 domains, we have these 5 priority questions corresponding to the indicators. And here you can see the simplicity, in a way, of the wording of these questions that we really, gave a lot of intensive attention to almost every single word in these questions to ensure that they would be as comprehensible and translatable no matter where. And also the same case for the response options as well. So for example, you can see in the practical issues, we have a couple of questions here. Do you know where to go to get your child vaccinated? No, yes, and then ease of payment as well, affordability. And so here, similarly, you can see we've taken a similar approach for our COVID vaccination survey. We have some slightly different items here that are specific to COVID vaccination for the unique vaccine, disease risk, and the recipients of these vaccines as well. So you can see a couple of differences here related to, for example, on-site vaccination and also the health worker recommendation and workplace norms. Again, a similar set of priority indicators all aligned, so that also this enables us to ultimately carry out this comparison between different factors or constructs or questions that enable us to then even understand these underlying barriers common to any vaccine or population for the immunisation program. And just a point as well on our qualitative questions in our interview guides, and these also correspond to the same constructs and domains, our 4 domains. So there's also, it facilitates this comparability between the survey questions and findings and the qualitative tools. So as an example, for our survey item on affordability, how easy is it to get vaccination services for your child? Here are the corresponding questions in the interview guides. So for a program manager, what makes the provision of immunisation a success in your area? Or for the health worker, I'd like to understand the process you followed to immunise a child starting from the very beginning. And with a couple of probes there to go a little bit further. So you can see how these touch on similar themes, but explore it at a different level for that different kind of data we're looking to gather. So as part of our work going forward, as of the work we presented to SAGE in October last year, and now the finalisation and dissemination of these tools and guidance, we're really supporting programs to think about how and why to be measuring behavioural and social drivers. And this is part of the work that we're doing to make the case for these important investments in gathering and using this data to not only understand these reasons for low uptake, but to also evaluate the corresponding interventions to learn what works in specific settings. So you can see there's a variety of different reasons here related not only to implementation, but policy making, planning, use of resources, transparency, ownership, even advocacy in various ways, supporting training. And this is all linked to the Immunisation Agenda 2030, which is the global strategy for this decade, which sets out some strategic objectives and priorities for programs, and our indicators there are aligned with these priorities. So a quick snapshot of some of our findings from 2 countries, just to give you an idea of what the reporting and use of this data can look like for 2 countries for COVID vaccination, and also showing here a comparison between health workers and adults. This is data that was gathered in a nationally representative survey last year. This is actually as we were validating the tools in July, August. And here you can see the distribution of different reasons for our 5 priority indicators. So showing, in fact, that confidence in the benefits of these vaccines is quite high. Family norms, perhaps a little higher for health workers compared to other adults. And also showing that intentions may be on the low side, but still showing that most people do want to get vaccinated, but perhaps also there being a gap in relating to knowing where to get vaccinated and perceived affordability of vaccination, particularly for adults. Making this comparison now to similar data gathered at the same time for the Democratic Republic of Congo, where we saw the confidence for adults a little bit lower here, but the norms very low. And maybe also this is because at a time there was not a lot of support from family, friends, other influencers, maybe not a lot of people yet were vaccinated at that point in time. In fact, very few, if any at all, I know. This was July last year, so I doubt that many vaccines had even reached DRC at the time, but also just showing what those social influences looked like as a starting point. Intentions here a little bit lower than in Ethiopia, but again, this knowledge about knowing where to go and perceived affordability very low as well. And noting that affordability does include these associated out-of-pocket costs in getting vaccination as well. So not only any expectations about being able to afford the actual vaccine, but maybe including the cost of taking a day off work to get vaccinated. So this is not just about the data. We really want to be helping programs to be using the data. The action based on this data is really what it's all about. So we also last year carried out a scoping review of effective interventions and organised these interventions by BESD domain based on the type of barrier that the intervention was acting on. And this is a starting point based on the available evidence to start to set programs in the right direction, in having some steps forward in knowing what kinds of interventions could be effective to increase vaccination. And to note that a lot of the literature is really heavily skewed towards high-income countries here. So there are a lot of gaps in terms of evidence from low middle income settings, but also in terms of having a standardized taxonomy for interventions that enables us to consistently know how interventions are defined and described, and the elements or that they consist of, but also just knowing what part of that intervention is actually effective. But we've put this together based on all the available evidence that we could find and the inputs of our expert group and partners to set programs in some direction to implementation based on this data. And also importantly, have found that these kinds of interventions are not just about more information and educational based interventions or more community engagement, social mobilisation. In fact, we're seeing an important growth in the evidence supporting interventions that are more behaviourally informed, that do help in overcoming these practical issues. And this is, in fact, what's the most interesting in actually helping to move people to a vaccination behaviour. And we've also, for simplicity and in helping to communicate and support programs to implement against these interventions, have organised these using this tree metaphor around 4 main areas of intervention. So focusing on quality and accessible services, trusted community champions who can connect vaccine recipients, eligible recipients, even parents for their children. So connecting eligible people to vaccination services. Also still underscoring and reflecting the importance of accurate information and supporting informed decision-making towards vaccination. And also these other types of structures and policies that really also importantly shape vaccination uptake too. Know that a lot of that is not really not going to reach its potential unless we have these other factors and activities in place. Importantly, underscoring the necessary political commitment to implementing and funding these necessary activities. So political commitment in terms of not only the investment, but in political leaders saying and doing the right things to support vaccination. We've seen that acutely over the last year or two for COVID vaccination and pandemic response more broadly. The importance of a strong health workforce, absolutely critical there across the entire system, not only for those at the front line delivering vaccination, and then in gathering and using this behavioural data systematically to understand those gaps and use it to monitor and evaluate those interventions as well. And so also to help programs in moving towards implementation of these kinds of activities, we've just published 2 added guides that elaborate on those types of interventions in much more detail. One is about quality immunisation services. And this is an evidence-informed guide for a variety of end users in a program, but really reinforces the importance of quality services and the components of quality services as well, and really aiming to direct programs to these data-driven and very people-centered strategies with some very practical and action-oriented steps for doing this at different levels of the health system, and reinforcing the importance of trust in the health workforce, as we know that health workers are often the most trusted person or point of recommendation or a source of information on vaccination as well. And the other guide we've also just published is on closing gaps. And this is an approach based on human-centered design for tailoring programs, co-developed with UNICEF. And this is an approach for very locally tailored, targeted services at almost a community level where there are these real inequities, and being able to work together with communities, taking a very inclusive and partner-oriented participatory approach to gathering that local data and working together to take a small step in the right direction with iterative, very straightforward prototypes and implementation of basic solutions to get the ball heading in the right direction to solve and address those gaps. And again, we're really thinking about tools and approaches here that are super user-friendly, adaptable, and straightforward for these local communities to be doing themselves. So based around these 4 steps that you can see here on the right. And really enabling programs to zoom in to these settings with a real low coverage, these hotspots with a lot of zero-dose children that are not at all vaccinated, or with outbreaks, or even where we know there are those pockets of hesitancy. And this works together with our tools on behavioural and social drivers as well. So just a quick snapshot of another publication that derives from the session we had last year with SAGE. This is WHO's first position paper on behavioural and social drivers of vaccine uptake. And this is WHO's global policy recommendation on this field of work. And it summarises our process and all of the evidence and findings of our testing and validation process for the tools and the indicators and corresponding guidance. It has the findings of our scoping review, where we identify those effective interventions, makes these policy recommendations about use of the tools and use of the data, importantly as well. And lastly, some future research directions, because there's still so much that we really need to learn and understand about the use of these tools and measures. And there are some gaps in our tools that we do need to take a closer look at in future, and also importantly in learning about these effective interventions in local settings as well. And we have recommendations here, for example, to national, regional immunisation technical advisory groups about their use of this data as well. So trying to establish this whole ecosystem of gathering and use of this data at all levels, local, national, regional, and global, where we're all starting to track and use this data in the same way that we might look at coverage data or surveillance data. So a quick summary recap on our recent publications here: the position paper, the tools and guidance on the drivers, and these other 2 publications, quality services and our human-centered design approach for closing gaps. That's where to find them. So that's all from me. Happy to take any questions and comments later in the discussion as well. Thank you very much.
Thank you so much, Lisa. I think that was a really useful overview, particularly in terms of contextualizing our COVID-19 work within the broader sort of historical learnings around immunization, recognizing that this isn't the first time we're trying to tackle a challenge like this, but also really useful to kind of go through that framework to kind of think about what those, how we define and what those key constructs are in terms of social and behavioral drivers, and how we can measure them in a tangible way and in a harmonized way, which is, I think, really important to all of the partners in this call. I know you began to touch on the importance of different sort of contextualized interventions, and our next speaker, Dr. Ruth Lawson, will actually be building on this and telling us a little bit about some of the things that have been learnt across Africa in terms of vaccine rollout and uptake so far. So Ruth, I'll hand over to you.
Thank you very much. I will try and keep my camera on, but if there's any bandwidth problems, I'll switch off, and please do interrupt if you cannot see or hear me. So yes, thank you, Lisa. That was an incredibly comprehensive overview. And I'm going to take it just a little bit further by giving an update on some work that FCDO commissioned to really try and contextualise this and look at specific examples in the African or lower middle income context of what actually works to get vaccines, to get jabs into arms. So next slide, please, Geeta. Context. Just to remind ourselves, there remains significant inequity in access to COVID-19 vaccine. We know that about 66% of the global population have received at least 1 dose, but that's only 17% in low-income countries. We also know that early in the pandemic, last year in particular, there were significant constraints in vaccine supply, and low-income countries that relied primarily on COVAX were not receiving the doses at the speed and the scale that they had anticipated. But that has now been overcome largely, And the challenge now is getting vaccines to people, the health system challenges of delivery, but also building the confidence and the demand for vaccines. And to illustrate this, to date, over 700 million doses of COVID vaccine have been delivered to Africa, but only 70% have been utilised. So there is supply on the continent, but people are not receiving and not taking up the vaccine. And what's most critical is that we should not forget the priority has to be reaching the highest risk groups. That's the elderly, those with comorbidities, immunocompromised, pregnant or recently pregnant women, and of course healthcare workers because of their risk and their importance to protect others. And it's also critically important to consider these groups in humanitarian settings. So although there's a big push to get COVID vaccines into arms, the real priority is to reach these high-risk groups. Next slide, please. So what FCDO did was commission a study. Yeah, great. Sorry. So the next thing, we also know that although we want to reach these groups, we also know that there are some challenges around people's perception of vaccines. And this is an illustrative study that was done by LSHTM and Africa CDC and recently published, or results recently released. And it looked at 15 African countries. And they found that overall across these 15 countries, 1 in 5 respondents said they would not take a vaccine. This is specifically COVID vaccine, even if it was safe and effective. And the willingness to accept a vaccine was highly variable across countries, with significant differences at national level, but also other studies indicate at subnational level too. And despite all the information that is already been circulated about the safety and effectiveness of COVID vaccines, many people still have concerns around the safety. And again, this varies depending on the demography and the traditional groups, that some show much higher scepticism towards a COVID vaccine than others. And there continues to be widespread misinformation and disinformation about COVID vaccine and COVID in general. And those who are exposed to this are also more likely to believe what they hear. Next slide, please. And so against this background, FCDO commissioned, move on to the next slide, please. Thank you. Against this background, FCDO commissioned a piece of work to really just a rapid review to try and answer the question, what has worked to get COVID vaccine nearer to people and turn this into jabs into arms, specifically looking in Africa and other low and middle income country contexts. It was a rapid review drawing upon published research, some grey literature, some interviews with key informants, but it was not a systematic literature review. So we do have to be careful in how much we interpret this. But I do want here also to flag thank you to many of you on the call who may have contributed to this by case studies or taking part in interviews, or perhaps where the researchers drew on some of the published literature and information that you had shared. Move on to the next slide, please. So what did this study find? I'm just going to share 3 key lessons that came out and some illustrative examples. The first point, and I think Lisa already alluded to this, is the importance of having accurate and convincing information from trusted sources. We know that in many African countries, governments are not recognised as a trusted source of information. So we need alternative voices, alternative approaches to deliver the messaging. Could be community leaders, religious leaders, family, friends, and so on. And just a couple of examples here. So there's a village chief in Malawi who's been quite recognised in the country as a true advocate of COVID vaccine. And he went round his communities, talking them to directly, outlining the benefits, and in his small area he managed to increase the vaccination rate to 57% compared to that 7% national average. So again, just illustrating the real importance of that trusted local voice. Or you can use media campaigns to access people through radio, through television and so on, such as done in Burkina Faso, and many countries have adapted these approaches. On to the next slide, please. The second piece that came out from this rapid review was the importance of reliable, real-time and disaggregated data to understand hesitancy and to target interventions. So again, an illustrative example came from Cape Town in South Africa, where the vaccine teams identified that in those communities, young men in particular were simply not coming forward and not willing to get vaccine, including those with comorbidities, high-risk groups. And so discussion took place in the community, and what they did was they got together some of the local artists to paint murals in kind of high profile places. And as they did this, they had music playing, they had DJs, really trying to create noise and buzz and a drive around the importance of vaccination. And they also supported this with pop-up clinics located beside these murals. And again, this led to a significant increase in vaccination among that young target young men population. Next slide, please. Then the third piece that came across from the evidence review, and I'm great, is the importance of accessibility. Again, Lisa referred to this. And the important thing is to make it easy for people to get vaccinated, particularly for the less mobile, hard to reach areas. So you could have pop-up vaccination sites, or using areas, putting up new centres, such as we do in the UK, community halls, using schools as centres for vaccination, or mobile buses. Again, works in the UK, but also works in many low middle income countries, just really focusing on trying to reach populations rather than expecting them to come to the vaccination site. Next slide, please. Then the fourth piece that came out of the literature is, again, the opportunity and the importance of integrating services, because this can save costs. It's using systems that people are already engaged with, but it's also an opportunity to reach your priority populations. And again, a small illustrative example came from South Africa, where at an HIV clinic, the team employed health promoters to actually go and talk to patients as they came for their HIV care, to counsel them on COVID vaccine, encourage them to be vaccinated, and offer the vaccine there and then at the same site. And so this was a small study in just a short period of time, but over 2,200 people of the high priority group were reached in that short study period. So again, integration, using all opportunities, very important. Next slide, please. And fifthly, and again, it's kind of stating the obvious, but the importance of innovative tools that can support logistics and information sharing. This could be things like solar powered technologies. It could be around using digital tools for data for training, but also for data reporting as used in Rwanda. Again, back to this real-time information, real-time targeting of information, and also using approach to target your messaging. And an example is WHO collaborating with WhatsApp and Facebook, sending out WhatsApp messages in different languages that share information about the importance of COVID vaccine and so on. Next slide, please. But the final lesson learned from this rapid review was the importance of local research to guide the interventions. Could I have the next slide? It's not come up for me yet, but I'll carry on in the hope that you can see it. It's really around the importance of using the local data and the local tools to inform the decision making. And research is really critical. So every country is unique. And it's been great to hear from Lisa about the BST tools and guidance. And I think these are absolutely critical to be implemented at country level, at subnational level, to guide the vaccine programme. And we have an example of this from a number of countries. It's actually Save the Children, who took some of the global tools, but also kind of used those at country level in 3 countries to really drill down at subnational level on what the barriers were and what promoted the enablers for vaccination. And they worked to create potential solutions, and they created this as what they called the Little Jab Book, which gives specific practical guidance for all stakeholders, those working at national level as well as those out delivering programmes on the ground. Next slide, please. And so just to conclude, I think it's very clear that large inequities continue in access to COVID-19 vaccine. It is in part due to systemic health system challenges, but it's also due to low demand and confidence in vaccine. And we can see that there's a range of approaches that are replicable that have been employed to improve uptake, but it's most critical that any strategy is underpinned by local evidence and behavioural insights, using validated tools, but honing down on these in the local context. But just to reiterate that an urgent need remains to reach those high priority groups. And unfortunately, there is less evidence available on how we might reach those groups, including in humanitarian settings. And so there is a need for that ongoing research, ongoing data management to understand best how do we target and how do we reach those priority groups before we roll out to the broader population. Thank you. I'll stop there. And again, happy to take questions.
Thank you so much, Ruth. That was fascinating, and I think it's so useful to learn about what these kind of global principles are, the commonalities across cultures and regions, but also just how important it is to tailor our approaches, both not just at the country level, but also thinking about how we might need to use sub-targeting and research to understand the specific needs of different groups within the populations where we're working. So we'll quickly open up for any questions and some chance for the presenters to respond. Lisa has been kindly responding to a couple of points in the chat. We've also made sure to share some of the documents that have been referred to in the presentations. But maybe I can start with a question that Kidus asked, which was about how we can also work with health workers who are often sometimes also resistant, and yet, as Lisa explained and Ruth touched upon, they are also very key in sort of building trust around the vaccine, among others. So maybe, Lisa, if I can open that up to you, if you have any thoughts on that. Oh, you're just on mute.
Yeah. Thank you. So absolutely, I think that we have seen for COVID vaccination, there has been a challenge in health worker uptake themselves. And this has been variable in a lot of settings, and where we have seen good data, this has been explained by a number of factors. Firstly, in fact, and we had some really robust studies carried out in the Americas region and parts of the Asia Pacific, and saw in fact that access-related barriers for health workers were predominant, and that health workers, as you can imagine, during the pandemic had been so overwhelmed and exhausted and had other life priorities that they were simply not able to go to the right place to get vaccinated. And that at the point in time, this was in the second half of last year, we saw that these access-related barriers, even for health workers, were the main issue. Since then, however, I have to say that this has become much more context-specific, and I would say that there has probably been an increase in other types of barriers, including perhaps confidence, concerns about safety, and also other types of norms that have held back health workers from getting vaccinated. And this requires locally tailored and targeted interventions. And in some of these settings where this has really been a major issue, we have seen other kinds of broader factors at play which relate to a lack of trust in authorities and political leaders and their decision-making, planning processes for vaccination. And also in some settings, health workers not even necessarily being adequately supported to do the work that they need to. For example, in some settings, health workers not receiving salaries for many months at this point in time, where there has been a lot of economic and social difficulties faced by countries during the pandemic, and those health worker salaries have not been adequately covered for many months in certain settings. And factors like that really we've seen are much more at the root cause of why health workers are not necessarily getting vaccinated. But to really adequately be able to address that, we do need better local data in to then really inform the corresponding actions needed.
Thanks, Lisa. And I think we did have one more question in the chat that was just about how the framework can be used in terms of that localization piece and really to generate contextual learning. Would you be able to respond to that in the chat for us, if possible? I just wanted to see whether, Ruth, whether there were any findings in relation to interventions targeted at health workers from your multi-country study.
There were not, and we were somewhat frustrated at the lack of evidence really on reaching some of these health workers and the other high risk groups. I do think, though, just to build, I think Lisa's absolutely right, and just to build on that, to remember as well, it's back to this idea of trusted peers and sources of information. And I do feel we're perhaps missing a trick with the health workers, because I don't think we have adequately engaged with their professional associations, because many health workers are a member of a professional association, which may be very weak or it may be strong. But I actually think we need to capitalise a bit more on that peer-to-peer network and try and engage more there. But unfortunately, yeah, didn't come out. As I say, it was a very rapid review, but no, nothing specific came out on that.
Great, thanks so much for sharing. And you know, hopefully there are continuing opportunities for us to learn from many of the HBCC partner programs. And so, you know, over the course of the year, we look forward to hearing a lot more about case examples from different regions of Africa and Asia. So we will move on. Thanks so much to both of our presenters. That's been really great food for thought. What we actually want to do now is give you opportunities to share amongst each other and to share your experiences of both the challenges of vaccine uptake and interventions that you've seen locally that seem to be working. So we're going to put people into breakout rooms. I think, Geeta, at the moment we can't quite see the slides. But basically, the plan is that we'll have you speak to 2 questions. We would like to know, firstly, what are the challenges that seem to be arising in your region? And secondly, what types of interventions have you seen working? And please feel free to share specific examples if you have them. We will sort of break you out into random groups. There'll be 4 groups, and within each group you'll also have a note taker. So don't feel like each person has to sort of take notes. We'll have someone dedicated to do so. So you'll have about 12 to 15 minutes in your breakout rooms to discuss these 2 things, to share and learn from each other, and then we'll have opportunity to feedback afterwards. So Rhodes, I think if you can initiate the breakout rooms now.
Okay, should be assigning people now.
Great, so hopefully you can all see a notification in the top of your screen and you should enter the room in about 10 seconds.
Okay, so there's a few of us still in the main room.
Hi, Rhodes. Are we to remain in this room?
No, something's gone wrong. Okay.
I'm on browser, so that might be why it sent me the invite to go to a room, but it didn't bring me there.
Let me try again. So your name's coming up as one I still need to assign. Candido Faustina, I'm not quite sure you haven't been assigned. Let me try and... Oh, and Sam's back as well. Oh no.
I was in a room. It's just that I couldn't see other people in the room. I could hear them, but I couldn't like see myself, as if I'd been chucked out. So yeah.
Okay, let me see if I can reassign. Do you remember which room you were in, Sam?
I think I was in room 3. So I have a little pop-up that says room 3 with like a play or phone button on it. So I'm going to press play and see if that pings me into like a separate room and see what happens.
Let me try reassign. Okay, cool.
I'm not sure whether it's because I'm on my phone.
It might be faster. Let me see if I can. Okay. You should be in room before and it has assigned you. Let me try again. No, it's not letting me. And Lisa, I think you were in room 1 or 2. I can't remember. Faustino says you're not available. I think it's because you're on your phone, maybe. Yeah, Lisa, you've been assigned to room 2. I'm not sure why you're not in there.
Not moving. I can't see anything that's asking me. You may wish to call names for better coordination.
Do you see a breakout option
I can.
on the top? Is there a...
So I can now join 2, I think. So I'll try
Yes.
joining.
Okay, great.
Thanks.
Faustina, do you see any options on your phone at the top that says breakout?
No, but I'm just going to use my laptop now. So
Okay, good stuff.
take a minute.
And then I'll reassign. I think maybe I'll need to reassign you, but that's okay. We can do that.
Hello?
Hi, Faustina. I've just seen
Yeah, hi.
I can assign you. There we go. Okay, now. Which room had I assigned you? Actually, I'm going to put you in the room 3. There we go.
Okay.
Okay, hopefully it's shoots you off now.
Sorry, I cut off there.
No worries. I think we're back in the main room, right, Rhodes?
That's right. Welcome back.
Amazing.
So
the power.
We'll give people a few more minutes just as they rejoin the main room. I can see we've got about 16, 20 or so people, so we'll just wait for a few others to join. What we're going to do now is we will have our note takers summarize each of the kind of key points coming out of the different rooms, but we're going to come back to that in a few minutes. What we're actually going to jump right into is a short session presented by Jenny Lamb, who works for the COVID-19 Hygiene Hub and at the London School of Hygiene and Tropical Medicine. And Jenny is just going to talk us through some key resources that are likely to be useful as all of us continue on this journey around vaccine uptake. And then afterwards, as I said, we'll hear some of the key insights emerging from the breakout rooms. So over to you, Jenny. You're still muted, Jenny, sorry.
Can you hear me now? I just want to unmute there. Yeah, okay, so apologies for that. Yeah, so as Shan said, so I'm going to give you a quick run through of some key resources. So conscious you've had a few from Lisa already, which is fantastic, and some of these you might have seen or heard of before. So if you move on to the next slide. So at the COVID-19 Hygiene Hub, we have a resource which is accessible here. You'll see it's basically, showcasing how to integrate vaccine promotion into broader prevention programming. So key audience being your kind of WASH and response actors, really you look at how to ensure your work is sensitive to the vaccine rollout. In terms of future plans, we will be updating this, so because this was maybe about a year ago, but still relevant. So we'll be updating this over the next year with changes to evidence and practice, but also the great work that you'll be doing. Predominantly up till now, it's been informed by evidence and practice and so forth, and its contents vary from case studies to videos to and evidence and practice, and to really showcase how we can promote the uptake of a vaccine, and also in view of your preventative programs. So next slide. Okay, and then I really just want to commend the Vaccine Confidence Project as well. So there's a 15-country study, and they have a high-level report too. So we'll be sharing these by email. And in terms of countries relevant to you, the 15 countries have a range of countries covered. But for HBC partners, there's Cameroon, DRC, Ghana, Kenya, Nigeria, and South Africa. So we'll share those with you, and it gives a real rich data set across these countries to both inform your future and baseline interventions there. Okay, next slide. Okay, I won't dwell on this too much because I'm conscious Ruth mentioned it before but this is a really informative visual book as well, the little jab book, and some of it being contextualized in country too as well. So there's a link there that's focused just in Nepal too as well. Okay. I'm not going to go read through all the bullet points like the audience and contents and value added because I'm conscious we're short of time. But yeah, so this next slide is a social media listening and engagement toolkit. So this is not available online yet. UNICEF are finding a time and place when to release it because they want to do it through a campaign, and they've got other priorities given Ukraine. But again, very visual tool there. It basically really gives you a practical learning guide to design and implement effective data-driven social media campaigns, and it's for campaign managers and social behaviour change experts and so forth. Okay, so next slide. Okay, and then we've got the Behavioural Insights team. So some of you might have seen this already. So again, this is opportunities with behavioural science research. So this is ways in which we can increase the vaccine uptake. So that's another valuable tool there as well. So it suggests 4 approaches. So focusing on focus, refine, expand, enhance, and it has a number of examples of what has worked and what has less worked so well. So the challenges and successes there. Okay, next slide. Okay, and then we've got the FCDO behavioural considerations for COVID-19 vaccine uptake and rollout too as well. So there's which is based on the COMBI model, but then it's also got really fantastic practical behavioural design checklists as well, and a number of recommendations there too. Okay, so next slide. Okay, and then just one last thing there, social media toolkit for healthcare practitioners. Again, looking at ways in which we can build vaccine confidence messages for your health workers through vaccine safety development and vaccine reducing risk of sickness as well. So those are the three emergent themes, and for the health worker staff, should they be designing social media content. Okay, next slide. And then just to showcase as well, if you need further support, we're here as a team, so COVID-19 Hygiene Hub, and also the FCDO team, as well as the behaviour change forums like we hear today, and also the team's chat as well. So, and also just to recognise too as well the great presentation that Lisa's provided, so the behavioural and social drivers framework, that's incorporated in with the M&E framework through HBOCC2. And also as well, I'm aware this week we've got the Vaccine Confidence Project at London School of Hygiene and Tropical Medicine. They're having a retreat on Friday this week, so I'll be attending that, and I will share notes accordingly based on the discussions and thoughts being discussed there. Okay, so that's from me. Sorry, that was a really rushed springboard action of all the resources, but I didn't want to dwell on them too much because you'll get these slides by email anyway, so just want to go back to Shan better with more for the discussion. Okay, so thank you.
Thanks, Jenny. So as we said, we'll be sharing all of those so you can continue to refer to them. So it sounds like we've had some really useful discussions coming out of the different breakout rooms. I can start by perhaps saying that I think one of the trends in the challenges that we're seeing emerging from what people were saying was that when we talk about challenges to vaccine uptake, it's not that this is static. So initially, a lot of the challenges in many low and middle income countries was simply to do with accessing vaccines and getting them out to populations where they were needed. I think in many countries we're now beyond that phase. In fact, we're often entering a stage where sometimes vaccines are going wasted or unused by the use by date. There was perhaps then an additional phase where people were sort of where there was lots of confusion about the vaccines. There was obviously lots of different manufacturers, and that created some confusion. There was also a period where there were a lot of myths, particularly around the side effects or the kind of perhaps government or other intentions behind the vaccine. And then I think that the stage that most people recognize we are at now is that COVID-19 is no longer people's priority. People no longer, even though cases are rising in some areas, people no longer see it as a major health risk. And so it's much harder to encourage people to be motivated to get the vaccine. I think what we started to hear as kind of ideas that were working were some of the things that we've already talked about in this session. But I guess it's a point in the pandemic where we realize we have to be doing ongoing reminders and ongoing targeting to make sure that for those particularly vulnerable people, or people who are at high risk of severe COVID-19, we might need to work through community leaders to reach them. We might need to create, think of more mobile options. As you can see on this slide, an example of a mobile clinic from Côte d'Ivoire, finding ways of reaching people where they are and being very targeted in our approach. I think other points that came up were around sort of thinking about how we create conversations around vaccines and balancing the opportunities to listen to people's experience and to more actively engage or challenge misperceptions. And this can be quite hard to train people on at a local level. I think there were also recognition that sometimes there are structural challenges in working with governments, but many people also recognizing just how important it is to make sure that we are working alongside government and within existing systems. So people also saying that where possible, we want to deliver COVID-19 vaccines in an integrated way alongside other services. We also saw some exciting examples of things like drama or creative public service announcements, sort of using religious organizations as a way of kind of communicating and building trust around organizations. If there were other points that I haven't quite covered from our note takers, please feel free to add those in the chat. If we could go to the next slide, please. So just to let you know, we mentioned this at the beginning, but we will be sharing the recording of this webinar, as well as the slides and the links to key resources. We'll also be hoping to schedule future webinars just like this one, where we have the opportunity to learn from some of your programs, some case studies of examples of what is working on an ongoing basis during the continuing sort of changing nature of the pandemic. Next slide, please. So before we wrap up today, we wanted to get each of you to just reflect on one particular question. So what we would like you to all do is finish the end of this sentence. So the most useful thing that my organization can do now to support vaccine uptake is, and then we would love for you to write in the chat, you know, one thing that you think you may have taken away from today, or, you know, that you understand from your context, what exactly is going to be your priorities as you go forward on promoting vaccine uptake. So I look forward to seeing some of those in the chat as they come through. And so I'll hand back to you, Pippa, if there's anything else to wrap up.
Thanks so much, Sean. And yeah, I just would love to say a huge thank you to all of you for joining and contributing, and especially to Lisa Menning and Ruth Lawson for your really interesting presentations, and to the whole team behind the scenes at the Vaccine Data Collab and Hygiene Hub, especially, who have, and a big shout out to Rhodes, who's expertly navigated us through this this whole last hour and a half. Thank you for everybody. And like Sean says, we'll be arranging the next webinar. We're aiming for one a month over the rest of the year. So, and we've got some excellent suggestions from everyone so far. There's loads of links that have been shared in the chat. If you don't have them, we'll capture them and send them in an email with anything else. And the webinar is going to go live. If anyone has any final questions or thoughts, please do share. Have you, so Siobhan has said she's going to capture, share and support the use of up-to-date data on vaccine attitudes and usage. So there you go, there's one chat, and Tatiana says increasing trust again among health workers. Ian is going to learn more and have more explicit targeting for vulnerable people. So there you go, huge challenge on your baseline informative research, and but also in this forum to continue learning from everyone else. Please do keep those chat wave things coming, and I will bring us to a close now. It's just coming up to the hour. So yeah, big thank you to everybody, and we'll see you next time. Keep up the really amazing work that you're doing. Thank you.
Thanks everyone.
Thanks, everyone.
Thank you.
Thank you. Bye bye.
We have closing. Bye-bye.
Thank you, Tony. Thanks, everybody. Really great to see you all today.
Thanks, bye.
Mohammed is going to collect as much data as possible, learn more, and inform our audience through social media and radio. Amazing. Learn about BSD and the indicators. Margaret. Misinformation, context-sensitive materials. For teachers, yes, of course, school community. Really amazing learning today. It's good to have that opportunity to think, isn't it?
Should we stop the recording as well? Yeah.
Does anyone?
Yeah, and make sure that Rhodes saves the chat log if possible, so that everything is captured for